Good evening, everybody, and happy Wednesday. Thank you so much for spending your Wednesday evening with us. And we are so excited to have a conversation today about HPV's role in head and neck cancer. And am I pronouncing it correctly? Is it Wojtek?
That is correct.
Oh, yes, I got it right. And the last name, is it Mydlarz?
Oh, wow. Yes, you've been practicing Midlash. That is correct.
Yes. Oh, I'm so excited to have gotten her. So we have Dr. Wojtek Mydlarz here with us, and he is the director of head and neck cancer surgery at Capital Regional Center. And so we want to pick your brain today. So first, can you tell us a little bit about yourself, ending with an interesting fact that will let us remember you, aside from your wonderful name?
I was going to say, everybody should know how to spell my name. It just rolls right off your tongue. Wojciech Krzysztof Midlash. A lot of R's and Z's and T's and OF's. But I was, let's see, about myself, I was born and raised until the age of 11 in Poland. I actually came here temporarily, supposed to stay here. My father was recruited to join Kodak, believe it or not, Kodak, Eastman Kodak Company, and still retired with Kodak before it kind of fell apart. And we've stayed ever since there. And to be honest with you, I sort of stumbled into medicine purely by chance. I have a lot of things that sort of one leads to another without actually planning for it. But same thing in otolaryngology head and neck surgery, otorhinolaryngology head and neck surgery. Say that 10 times fast.
Right.
Similar reason. The reason I fell in love with this field was really as a medical student. I just happened during my surgical rotation, I had to do some electives, and because I was away studying for the boards, this was before the days of electronic media still, or emails, and fill out a form electronically. I never got the mail to say send in your form of electives, and I just happened to be matched, aka forced to take whatever was remaining, including otorhinolaryngology, and I think it was cardiac surgery was the other one, which both were fantastic. But yeah, I just stumbled upon the field, and I spent a lot of time in the clinic and then the operating room seeing the amazing things that are here in this area. I call this the Manhattan of our bodies. Okay. The neurosurgeons think it's here. I tell them
No,
very quickly that without this, there's no brain. So we
understood.
win. So we win. So it was really the intricate anatomy, the complexity. I mean, it's really, I mean, this doesn't get more high stake game than in your neck and skull base and towards the brain. And so is that challenging anatomy and minimal anatomy and lots of disease processes that can happen in that area that really tugged at me, and that's sort of how I fell into that field. And it started out with when I saw the really big cancer surgeries and procedures and reconstructions. That's really what struck with me, and to this day, as you can see, I'm still doing it. So it's sort of interesting how one falls into certain things. I think sometimes that's better than trying too hard to do something.
It does,
So I'm
right?
very
It
fortunate,
seems
very
like you
fortunate
stumbled
to be
into
where
the
I
right
am.
thing.
Yeah.
Seems like you stumbled right into the right path
Yeah. So far.
so far. And that's interesting that you grew up in Poland and then you made your way here. So that's an awesome fact. I think I can remember that. That's something that I'll remember after this.
We could do this webinar in Polish if you'd like,
Uh,
for the Polish speakers in the world here. I'm kidding.
you
I
know,
won't torture
we,
you.
we might have to circle back and
Nice.
do that. So, well, my next question was actually going to be, what inspired you to go into head and neck cancer surgery? But I see now that you just stumbled into it and you seem to have enjoyed it, correct?
No, it is. I think the other part of this is for the same or similar reasons. This is an area that really, well, first of all, it's visible, right? Anything here is
Yeah.
who we are. That's how people recognize us. That's how we self-identify, others identify us, computers identify us, whatever, robots identify us. But it's also an area where the function is critical. Without function, we sort of fall apart. We are less of each other when we don't function well in this area. So in terms of speaking, talking, swallowing, breathing, and all those facial function, right, expression, all those things. So again, these are all things that tumors or cancers or however you want to think about disease in this area, not necessarily even cancer, can affect, and the complexity of that and how it affects not only the patient but the family and the society around them, right? sort of how they see each other or see themselves outside in the community and how that affects them, but also others, right? It's a very area where you have a lot of disfiguring cancers or things where you need to do reconstruction. So the goal of treatment is obviously to treat the cancer, but not so far behind, maintain function and form. And I think it really is in that order, but they're all really pretty close. We try to maximize each as much as possible. Obviously, it's impossible to do at all times, but we definitely look at sort of when we look at treatment modalities, it's not always surgery, it's not always radiation, it's not always this. It's trying to figure out what's the most effective or all the effective treatments. And then sometimes, and hopefully, people have choices, and it's good to have a choice. So, speaking of what we're going to talk about, there are
Right.
some choices where we can do certain different ways of approaching it without sort of compromising on form and function.
So with that, as we're looking at trying to make sure we're maintaining form and function as well as the best form, what about prevention? What part of your job, how much of the role goes into educating patients about ways that they can prevent head and neck cancers or early detection of head and neck cancers?
Yeah, this is a place where it's a little harder for this area because I think that's still being developed in many ways. But number one, the what we call the gentlemen's or old school head and neck cancers are usually smoking and drinking related. We do know that tobacco exposure, even secondhand exposure, that includes now there's data to show even other illicit or legal or not legal substances as well, including marijuana does increase your risk of cancer. And then that alcohol extension or alcohol exposure exponents both. And because the way to think about alcohol, just like tobacco smoke, not only does tobacco smoke have carcinogens or other smoke has carcinogens, in addition to that, it's also an irritant, and that's how we think alcohol sort of contributes to this. It's a chronic irritant, drying agent that unfortunately continues to force your lining to regenerate or recover from the insult of chronic alcohol exposure, combination with all those. So it's sort of a combination of that. But that's, to be honest with you, at least in the US, that's becoming less of the reason for head and neck cancer, although it's still an important one. The other one, which I'm sure we'll touch upon, is human papillomavirus and other viral driven, and it doesn't mean cause, but just driven cancers. So Epstein-Barr virus or what's mononucleosis basically, as well as the human papillomavirus or HPV, otherwise known, similar to the association or causality with cervical cancer. It can lead to a lot of head and neck cancers of the throat. And what we mean by the throat, it's sort of the tonsil area, the floppy part of the palate in the back of your throat, as well as the back of the tongue or the base of tongue, because back there you also have something called a lingual tonsil. Most people don't know you have your regular tonsils, but
Mhm.
you also have a lingual tonsil. And believe it or not, also this has been now seen as a potential risk for sinonasal cancer. So cancers within the nose or the sinus cavities or even the nasopharynx, the nose throat. So the part that's above your throat, behind your nose, can also be driven by not only Epstein-Barr virus, but also human papillomavirus. And to be honest with you, right now, we still calling it, it's still an epidemic of head and neck cancers or HPV, especially HPV driven cancers and sort of in the developed world. In the Middle East and Far East, it's really the Epstein-Barr virus, cancers that are really still very, very prevalent, and are probably the majority of cancers there. So Hong Kong, China, Japan, Korea, a lot of Epstein-Barr virus, especially nasopharynx cancers, are driven from that. So it really depends on which part of the country you are and sort of the exposures that you have that are really prone to that. But it's the number one cancer right now for head and neck is HPV associated, meaning human papillomavirus associated. Doesn't mean it's caused, but it's associated with exposure to the high risk human papillomavirus. And the most common way that the people present, it's the most common way I see people in clinic, and not just myself, the team sees that people in clinic is with a neck mass. That's how you present, meaning it's already spread into a lymph node. What we know now is that it's still not the end of the world when that happens, but that's the most common way that people will present. So looking out for neck
So,
masses, bumps and bumps.
So what are the current guidelines for screening? What about people who may not have had symptoms yet, but what are the processes for getting screened for head and neck cancers, especially as they pertain to HPV?
So the good news or the bad, well, there's no good news, I guess. The good news is, or there's no bad, but the bad news is that we don't have anything available yet. But people are working on it. People are looking at rinses in the saliva and other areas. They have none of that's been really proven. To be honest with you, it doesn't. We don't have a good screening program. So for people who are high risk, high smokers, drinkers who already had another cancer, let's say another lung cancer, an esophageal cancer, then they do undergo a much more close evaluation and screening for other tumors, because we do know that once you have one of these tumors, just like we screen for other ones, you're at risk for developing a second tumor. So if you have a head and neck cancer, you have a very an elevated risk of getting an upper GI cancer, meaning esophageal cancer or lung cancer, and vice versa. So we kind of look at those. There's no known testing or screening strategy for it that we know of to date. The What I usually tell patients, because patients do worry oftentimes, and oftentimes they will, especially more women, will get an HPV positive screen on their cervical smear, and they'll come in saying, I'm HPV positive, I'm worried about throat cancer, can you please screen me? And I tell them I'm happy to look at them. It's just there's no formalized screening process or a blood test or imaging that we do, and so it's really just prevention more than screening is very important. I think that we have a great chance to really improve our prevention of these tumors with vaccination. I know it's hard to say vaccination is geopolitical climate, but truly vaccinations, and I think that's what's going to change the tide of what we're seeing in our practice, but also in our children, and also help obviously with cervical cancer, which actually we've already seen that the rates of cervical cancer have drastically gone down with the vaccination efforts in women. So I think that's. I wish there was a screening test, but we don't. We do offer. There are spouses that have head and neck cancer patients, and specifically the human papillomavirus cancers. Statistically, they're not any more at risk that we know for developing their cancer, but we feel, or the way we think about the etiology for these human papillomavirus cancers is that at some point in their adult life, they were exposed to a high-risk strain of that HPV virus. And it takes many decades for these tumors to develop potentially from that exposure. Not every exposure leads to development of cancer. And so likely if they've been in a monogamous or longstanding relationship, there's a chance that they likely swapped or were exposed to the similar strain of virus. And so we do say to patients and their spouses that that we should keep an eye on it. But again, there's no screening. We just say really pay attention to your symptoms. Complaints of a glop feeling that doesn't go away, or difficulty swallowing, or a neck swelling or neck mass, come in sooner than later just to have it checked out, just to make sure it's not anything. And more often than not, it's not. It's just a little lymph node or something else, or a viral infection. But we do know that there's a little signal that there may be a little elevated risk for developing cancer, but it's not statistically significant.
Hmm. So before we talk about the vaccine and other ways that we can prevent HPV, I'm sorry, how, well, you said that HPV influences, can you explain that a little bit more as far as it not being the cause of the head and neck cancer or throat cancer? What do you mean exactly by influences the cancer?
Yeah, so we try not, because it's hard to prove causality. If you talk to any lawyer, it's very hard to prove causality. But the way we think about this, the way sort of a lot of us explain this to patients is that it's a driver, it's a contributor, and some people may be the dominant driver for development of cancer. It's really a combination, we think, from what we know, of partly some genetic changes, so your genetic makeup, partly a lot of environmental exposures, whether there was a little, whether it was smoke or whatever environmental exposure you were exposed to, and the higher risk HPV. Now, there's many different types of HPV subtypes. Only a few of them are the high risk. The interesting part is that the high risk types for cervical cancer are different than the ones for the head and neck cancer. The good news is, and we'll get to that, I'm sure, later, is that the vaccine covers both, which is good news, the major ones. But they are different subtypes that are a risk for cervical cancer versus head and neck cancer. But it's really the way we think about it is human papillomavirus, you don't know you have it. And so oftentimes when you get it in your throat as opposed to down into your private area, is that it just feels like a virus, like just any other, upper respiratory infection, congestion, maybe some sore throat, who knows. It's usually, it is a sexually transmitted disease when you think about it. So it's usually due through direct contact or fluid exchange. And so at some point, if you're sexually active, whether it's oral or vaginal sex or whatever it is, you get exposed to that virus. And like I said, it may just feel like a cold, and then you shake it off, your body gets rid of it. In most cases, our body is amazing at getting rid of viruses. In a small percentage of patients or cases, that virus, instead of being completely cleared from the body, gets integrated into your own cells in the lining of your throat or lining of your vagina or uterus and other areas. And it just stays there dormant. But we know is that those genes or the signals that get integrated are very much similar to the herpes simplex or cold sores. They may always have a little activation, always have a little bit of their signals be produced. And we do know that they offer an advantage to those cells that have them to live longer, not to die as easily. And so that's how we think that these develop along with other changes in the cells or the region that will then develop these tumors. Now, in many of those patients that get the integration, doesn't lead to cancer. So it's still a small percentage of those that then end up developing cancers. Now, but because it's such, we think, a common occurrence that we're seeing a lot of this because of the sexual revolution, that right now we're still sort of trying to get through the wave of these human papillomavirus associated cancers because of the changes in sexual practices and societal norms and everything else. So I think the vaccines will have a robust change in that, hopefully in the near future. But
No. Well,
so
nice.
so
Nice.
so it's not nobody was cheating on you. It's just this was something that was many decades before of something that occurred when you were much younger, usually in the teenage years, early 20s is the best understanding that we have.
And so I'm sure because it's something that usually happens in teenage years, early 20s, this is why we want to vaccinate children starting at 9 years old, correct?
That
Can
is
you?
correct. And so my kids we're a little behind. And I have an 11 and a 13-year-old, but it's definitely on this year's agenda to get the series to be done. And it's a lot of scary. The Gardasil is one of them, but the vaccine has been safe. There is some litigation against some of these things, and I know that was in the news. But from what we know, these are very safe vaccines for both adults and kids. The younger you do it, the less amount of doses you need to really be covered for it. But it's usually at least 2 doses when you're younger, and then it's 3-dose series of 3 shots to get the immunity that you need. And right now, the recommendation is really to go all the way up to the age of 26, but you want to try and do the vaccination when it comes to kids before they're sexually active. So that's hard to predict or control sometimes. So usually try to do this in the prepubescent kids. And then again, that usually just means 2 doses is enough to do that as opposed to the 3. But again, the idea is that you want to get immunity against the high risk HPV prior to the first sexual or whatever, it's oral sexual or whatever sexual contact it is, to minimize the exposure. And if there is an exposure, to have the body have the ability to neutralize the virus so it does not integrate into the cells or into the lining.
So you mentioned somebody older can get it. I guess I was under the impression that, or maybe a lot of people under the impression that it was only for ages 9 to 11 for children. So an adult can get the series as well.
That is true. Yeah, the guidelines used to be up to the age of 26. Now they've extended it up all the way, I think, to 45, I want to say. Either 45 or let me see if I can, I wanted to look that up earlier today, but I think it's up in the mid 40s at least. And the reason for that is, yeah, 45. 45. There is, again, it's not for everybody. So that should be something that's discussed. Because again, most of the exposures usually will happen in the teenage and early 20s, because by the mid 40s, most people are monogamous or have very, very narrow sexual exposure risk. And so then the benefit from the vaccination may not be as great. Now, the reason we say that is the norms are changing. People are getting married later in life. They're continue to have multiple relationships into their 40s, if not their 50s. And surely we have patients across all age ranges. That is correct that most of the, especially for the HPV tumors or human papillomavirus tumors, most of the demographics are in their 40s or 50s, usually in the mid 50s or so. But we have plenty, we have a sort of, it's a bimodal distribution where people in the 40s and 50s, early 60s, and then it kind of goes down, and then 70s, 80s goes up again. So we have plenty of patients in their 80s and later that develop these tumors. So you can imagine, again, with the idea, what we understand about these is that it takes about 3-4 decades for them to develop. Likely they were exposed at some point in their 40s or maybe even 50s to this virus that then led to the development of this tumor. And so that's what led the FDA and CDC and others to expand the registration or the approval up to the age of 45 for that reason. So again, it's not for everybody. So if you've been married already and you're 30 and you're in the same relationship, probably too late. But if you're still not married, you may not get married and you're continuing to date and are exposed to multiple partners, then it probably still may be a benefit to you to undergo the vaccination. So that's why the expansion of this.
Oh, that's actually really good to know. I don't think a lot of people may have known that, the vaccine has been extended to that age. Now, is there any harm of, especially, I'm a parent of young children who haven't quite got to the age of needing the vaccine, but it's coming. The conversation is coming soon. So are there any harms or things to consider as a parent for giving the HPV vaccine at such a young age?
That we know, sorry, not that we know. The people, these would not be recommended if there was no safety data on it. So as far as we know, the most common reaction to the vaccination is just some soreness, maybe feeling a little under the weather, and obviously the fear of the needle, right? The experience of getting the vaccination. But as far as we know, besides just very similar to any other vaccination that you would get, just local arm reaction and maybe a little bit of swelling, some lymph nodes. But that'd be unusual. So as far as we know, they're safe. Obviously, it's hard to really be 100% proof on anything you do, right? But as far as we know, that are very safe, including kids. That's why the indications are to such a young age, and you don't have to do it right away. It's just the sooner you do it, probably the more effective it will be at preventing having not only exposure, but being able to neutralize the exposure to the high-risk HPV or human papillomavirus.
Okay. That's reassuring, especially the HPV vaccine has been out for about how long now?
I think it was, oh gosh, it's been at least 20 years. That's a good question. I never really thought about looking that up, but yeah, it started coming out when I was starting out resident. Yeah, so I think it's been at least 20 years out in the market.
That is also good to know. Sometimes longevity seems to make somebody feel better the
Yeah.
longer something has been out. And so now that we have passed, the vaccine, and let's say somebody does encounter head and neck cancer that is related to
2000 and I just looked it up. 2006.
Okay, we're
We
about
got
to get 20
FDA
years.
FDA approval in 2006. At
So
least
next
the
year will be
Gardasil
20
one. Yeah,
years. Okay.
2006.
And I haven't heard of any other. Is there another
There are a
aside?
couple other competitors that they have a little bit of various stuff, but yeah, but the Gardasil is the most known one, and that's the one that's probably most covered by most insurance areas. So that may be sort of a justification, or not justification. The choice may be up to the insurance company as to what they would cover. But yeah, that's probably the most common one and the most studied one in terms of use and young and the young adults and the younger kids.
Okay, oh, that is definitely good to know. Most studied. That makes me feel more secure as a parent. So when it comes to patients that you see that present with a cancer of the head and neck or neck, what does that surgery end up looking like? What does that treatment look like for that patient? Where are the locations that you normally find the tumors for this patient?
Yeah, so it could be anywhere. So head and neck cancer is really a general term to literally anywhere in the head and neck. So It could include the salivary glands, skin cancers, right, including melanoma, basal cell carcinoma, squamous cell carcinoma, Merkel cell carcinoma, which is a more rare, also
Mhm.
a viral-driven cancer, skin cancer out of all things. Then there's thyroid cancer, right, which are probably the most common. When you think about number-wise, thyroid cancer itself is the most common that we deal with. Then there's salivary gland cancer that we talked about, and then there's the lining cancer. So there's other also more rare types like sarcomas of the muscle and other tissues, and there's other tumors like that. But most of them are on the lining side. So the lining, anywhere you can think of the shining, smooth lining inside your mouth, inside your nose, inside your sinuses, all the way down to basically your voice box and below, you can get cancer there. And so it's because it's lined by squamous cells. So I think most people, when they think about head and neck cancer, that's what first comes to their mind, and squamous cell carcinoma. And that's the one which is the lining. It's just cancer of the lining of your upper aerodigestive tract. And that's the one that's also right now the most prominent one, or the most prevalent one, is the HPV positive, at least in the US and the Western world. But you also have to think about the ones that are not HPV positive. So they're different every site has a little different risk profile, a little different approach in terms of how you treat it. But the mainstays of treatment still to this day, although it's about to change, and I'll get to that in a second, is surgery. And the question is it surgery by itself, or surgery with radiation, or surgery with radiation and chemotherapy? We try not to do all three, but sometimes the pathology and the disease sort of forces the hand to have to do all three. Or is it radiation by itself, or radiation with chemotherapy as an option? And so, and I'll sort of divert very quickly. So for human papillomavirus, what we know is those tumors that are usually in the tonsil, the base of tongue tonsil, the throat, or the palate, we know that in terms of effectiveness, surgery plus radiation, or radiation plus chemotherapy, so surgical or non-surgical treatment, are about the same efficiency in terms of treatment. Recurrence, so they're about the same, they work the same. So the question is, which one do you choose for which patient? And again, this is when the decision of what would surgery do for their function and form, is that worse than radiation would do? And then so we decided and more or less that's the way we think about it. So depending on the location, the size of the tumor, where it is, we sort of tailor whether it's surgery makes sense or radiation makes sense. And then we sort of wrap the treatment around those two main modalities, because those are really the two main modalities. Adding the chemotherapy and now immunotherapy, this is where I'm about to touch base, is changing the game a little bit. For the non-HPV, so with the sort of the more standard head and neck cancers that are either smoking or drinking related, or just poor genetics, there are definitely genetic disorders that make you more prone to head and neck cancer or the lining cancer. Usually surgery is the mainstay for them. So because they don't respond as well to non-surgical treatment. So all the other ones that are not human papillomavirus or Epstein-Barr virus positive, which is still a big portion of head and neck cancer tumors, surgery is the mainstay of treatment. And depends where it is, there's a lot of cost to pay in terms of form and function. So you can imagine if it's the upper lip or the tongue,
Right,
you end up
right.
losing part of that tongue it's always the tumor plus a number, or at least a centimeter of margin. If it's in your jawline or around your teeth, you have to take a segment or part of the jaw and then try to reconstruct the mandible or the jaw, including the teeth. If it's in the back of the throat, same thing. You have to reconstruct your swallow tube. If it's your voice box, that's the hard one, where if it's a smaller lesion, oftentimes you can do laser or partial resections, which will still affect your voice and maybe your swallow, but it still will maintain your function in terms of your voice box and swallow. But bigger, more advanced tumors, you have to end up thinking about removing the entire voice box to really disconnect, removing what makes us human, to vocalize, and remove that, and then reconstruct that area to make sure that you can at least swallow and breathe, and you separate those two functions, because right now we breathe and swallow in the same single area. So it's amazing that we don't have more issues with aspiration. But that's a difficult one. Now, the good news is that you can reconstruct that. You can actually have even though you remove the voice box, you can actually have a prosthesis, a little prosthesis put into the place where your voice box was, and still learn to vocalize. It's called tracheoesophageal speech. So you're using your esophagus to actually speak. And there are patients who are very willing to meet other cancer patients who have to make this decision and think about it, where they meet, first of all, they can meet them in person, they can talk to them on the telephone or do a video conference. Why? Because they are able to vocalize, even though they don't have a voice box. And of course, the things that you see in the movies, the electrolarynx, right?
Uh-huh.
The robotic voice, right now with artificial intelligence, that's becoming such an amazing tool. And there's a lot of development of that just with even an implant, or you put a little sensor here that people can talk and have, if they have a recording of their voice,
Their
artificial intelligence can actually formulate the paradigm. So when they actually want to speak, it sounds like their voice. So
No,
we're
I
not
have
there yet.
I
That's
have
getting
2
there.
questions. One question's from me, and then one question I have from one of our attendees. So in the chat box, they said, "Is the actual tumor tested for these viruses before the treatment decision is made? So is there like a biopsy done, and then you make the
Yeah. Yeah, it's either done on the wherever the source of, or you always want to localize the source of the cancer. So like I said, the most common presentation for head and neck cancer is a neck mass. So that comes on out of the blue. You're not sure how long it was there, but it doesn't go away. It's oftentimes that means it's a lymph node. It could just be a normal lymph node or just some swelling of a salivary gland. But as you get that tested, it looks abnormal. You get a biopsy of that. Because sometimes these tumors, especially for the human papillomavirus tumors, are very small and are very hard to see, even with your eye and special endoscopes we use and even imaging. But yeah, you test either the lymph node, or if you know where the tumor is, the lesion where it came from, into the lymph node, you sample both. And it's exactly true that we tested for many things, but one of them is human papillomavirus testing, depending on the location. Like we mentioned, sometimes it's the Epstein-Barr virus that we test for as well as in the blood as well. And we test that for, because that actually, it's a big sort of fork in the road in terms of what the options are.
So here in the Western world, does race play a role in whether you test for the Epstein-Barr virus?
For that one, yes. For HPV as well, HPV or human papillomavirus, again, you can get tired saying that many times, but it's a little less prevalent in the African American patients, but not that doesn't mean it doesn't happen. Epstein-Barr virus for sure, and it's interesting. It's not really ethnicity. It's meaning, did you live in the Far East, and grow up in the Far East and move to the U, or just stay there? Because same thing for whites and non-whites and Asians, similar thing, but it is usually of the Far Eastern sort of demographic that especially people from Hong Kong, China, Korea, and Japan are more prone to developing nasopharyngeal cancers from Epstein-Barr virus, but even more so if they actually live there, or were raised in that. Because again, there's a component to that it's thought to be environmental in many ways, environmental exposure as well as the viral exposure. And so those tumors in the China, Hong Kong, Korea are very prevalent. So they're actually probably more common than any other tumor. That includes Taiwan, Singapore, and all those other areas in the Far East.
That that is actually like interesting. So it's more so about where you live rather than, because I can be an African
And their
and
and their rate of HPV cancers are much lower, just like in Africa and even Middle East, or even Eastern Europe and South America. The human papil or the human HPV virus cancers are much less prevalent. They're just not as common as in the sort of industrialized Western world.
was that analyzed at all? Could that be attributed to
Yeah.
lifestyle at all?
Potentially, yeah, like lifestyle and social norms and lifestyle, right? And also sort of where the virus is endemic, right? Sort of where the virus, remember, the virus has to have a host. So if it doesn't have a host or hasn't spread to an area, you're not going to see a lot of that viral or the viral exposure. So it's very similar to the cervical cancer as well.
Oh, understood. Okay. And so my personal question came from what the treatment options, like you said. One, what does that look like for somebody that might have to have, a mandible reconstructed with their teeth, or the soft palate of their mouth reconstructed? What does that recovery time look like for that patient?
So if all goes well, typically it's about a week, sometimes a little longer. We, as much as we can, and that field has really changed probably 25, 30 years ago, where we now have the capability to do microvascular surgery, where we literally do auto transplants from the patient. So it's hard to do transplants from others because there's match, just like, when they do organ transplants is really difficult. Plus, that usually entails being on anti-rejection medications, which sort of subdue your immune system and increase your risk of of developing cancers. So one of the populations that we really struggle with are the transplant population. So patients who have had a bone marrow transplant or an organ, a solid organs, more specifically kidney, liver, others, they're on very high doses of anti-rejection medications, and they have a much higher risk of developing cancers, including the lining cancers. Probably most common are the skin cancers, but they can be very aggressive because of the fact that they actually are subduing their immune system to not reject the organ, but it's also preventing your immune system to, believe it or not, do surveillance and potentially treat and kill pre-cancers and cancers. So we've learned sort of the power of immunotherapy and our immune system to be able to really help us in that effect. So, but yeah, so typically we would auto transplant. So if it's a soft tissue defect, oftentimes we can also do regional flaps. We borrow things from the chest wall, including the skin and muscle, called the pectoralis flap. So when you do a push up or a bench press, that muscle and that tissue over it. There's also tissues in the back of the neck as well as the side of the chest. We can also, inside the mouth, use the cheek. We can actually swing the cheek over to the tongue if needed to. We can do a submental island flap to move sort of tissue from underneath the chin and give you a little chin lift and flip it upside down and put it inside the mouth. We can do a supraclavicular flap from here. And as seen, there's many different regional flaps. And then there are these free flaps or microvascular auto transplants where it's usually the forearm right here, the skin, dermis, some of the muscle here. You just take that off with the artery and the vein, and you disconnect it here and you put it wherever you want to reconstruct, and then you plug it into the recipient vessel, artery in the vein, and the graft lives and sort of takes its new shape to reconstruct that area that was removed. For the jaw, it's a little, or the other one is the thighs. You can actually something called anterolateral thigh free flap, where you move skin, fat, and muscle from your sort of lateral thigh in similar action. Sometimes we use the rectus abdominis, so sort of some of your stomach, skin, fat, and muscle as well. And actually a common reconstruction for breast cancer as well, potentially. And then for bone, when you have a bony defect or bony loss, those are more challenging to do, especially when it has to do with the cheek sinuses or the jaw. The jaw is unique because it's a ring. It's a ring that has to rotate, slide, and move. And if you break it at any time, it just sort of gets off kilter. So you have to reconnect the ring and make the ring whole again. And so oftentimes the tissue that we use is either from your scapula, so from the back of your shoulder blade, with an artery and then so bone, muscle, and skin and fat with artery and a vein. Or you can use your fibula bone, which is your leg bone next to your ankle. It's the one that we don't really think we need unless you're a ballerina or a field goal kicker, maybe a hockey player, because that's a bone that we don't need for stability of the leg. So we borrow actually up to, can actually you can do a total mandibular reconstruction with that leg bone. You can take as much of that bone, as much of that with the artery and the vein. The other one is also from your sort of your hip that you can remove some of the bone. And worst case scenario, you do have a bone in your arm on the radial side. It's called the radius. And again, that's a little harder because you have to put a big old reconstructive plate so you don't affect the strength, the ability for your arm not to have a problem. So that does limit, but that is also in the worst case scenario, we sometimes use that as well. So we've learned to use tissues from other areas to try to sort of fill in the defect. It's never as good as your original mandible, but the idea is to, wherever the missing segment is, to fill that in with also a reconstruction bar, sort of similar when you would do if you would break your jaw in terms of trauma or whatever it is, to sort of help stabilize that with additional structure. It's usually a titanium bar with the bone, with its own blood supply, sort of allowing it to heal to the two cut ends of your jaw. So that takes several weeks to months to do, but you can actually have that entire bone get integrated into your jaw, or if it's in your sinuses or anywhere else, to give you sort of maintain the form and function of your face and your facial characteristics. You can get those in there to actually start growing in with the rest of the bones. So it's actually amazing that we can do that.
Several surgeries, I would imagine.
It's usually done with one surgery, so it's one
really?
big surgery. Yeah, oftentimes when we do if we need to do the removal of the tumor and the reconstruction, the major part of the reconstruction happens at the same time. So it's usually a team surgery. While let's say I do the resection of the tumor, the reconstructive surgeon, they sort of start. You oftentimes can't do the entire thing until you know exactly what the defect is, but
Right.
Oftentimes you can get access, start doing most of the surgery, and then so it's done at simultaneously at the same time. So you save time, but also obviously there are different parts of the body, so we can have two different OR teams working in the same room. So it gets a little hectic at times, but it's done at the same time. So that's the good news, is that it can be done at the same time, and oftentimes it is. Every once in a while, we have to sort of stage these if it's a sort of more challenging pathology, to make sure that all the tumor is gone. Because obviously you don't want to put a reconstruction in somewhere where you're not sure if all the tumor is gone yet. So sometimes you have to stage and just do the resection, wait a couple of days for the pathologist to give you the answer, and then come back a couple of days later to do the reconstruction. But most often than not, it's done at the same time.
Okay. Now, when you have to wait for the pathologist, are there ever instances where maybe the patient has to undergo radiation or chemo prior to the construction?
For head and neck cancers, that's rarely done. For most of the tumors, the radiation is usually done after surgery, if that's if the primary way to treat is with surgery. Like I said, there are tumors, especially the human papilloma and the Epstein-Barr virus tumors, where we treat with radiation up front. And sometimes those tumors or the lymph nodes or wherever the cancer is doesn't get treated or doesn't respond completely during the treatment, or it just recurs. Many, a year or two later, there's an area that comes back or grows back. And oftentimes then you actually do surgery. It's called salvage surgery. So sometimes you do surgery after radiation. It is a lot more challenging to do it after surgery. After radiation. The most common type is, in these days, is actually people who undergo radiation to their vocal cords or voice box cancer for smaller lesions, because those are actually two options. You can do surgery or low dose, or not low dose radiation, but radiation. When those come back, oftentimes they require a major surgery. So when we talked about removing the voice box, we would do it then. But then it's more challenging because it's now radiated tissue you're doing this through, and you're trying to put everything together. And oftentimes when that happens, you have to do surgery and reconstruction. Because of that reason, the healing is not as good as it was before once people are radiated, because it's just radiated tissue with a very much different blood supply. So it's a lot harder for the tissues to heal without any issues. So it gets a little bit more challenging afterwards. But oftentimes, if it's surgery, it's usually surgery first, radiation second.
And in the recovery period for the patient, what is probably one of the biggest challenges that they might face after, the surgery, after having had a head and neck cancer?
Yeah, so it depends really where the tumor or the cancer was. Like I said, the rehabilitation for, let's say, I'll break it down by site. So from voice box cancer, it's sort of oftentimes when it's a laryngectomy, removal of the voice box is the suctioning, and sort of, if you have a prosthesis, learning how to use the prosthesis once the swelling goes down. But really the suctioning and not being able to say as many things as you want to do right away. So you have to start doing learning, writing on boards and other things. In your throat, it's really the swallow part, relearning how to swallow safely, meaning you have to wait for some of the swelling to go down. You start working with our speech language pathology rehabilitation team right after surgery. Maybe not immediately right after, but even as you're recovering, we start working with our SLP team to make sure that it's safe for you to swallow once it's safe to actually start to swallow. And then to do certain rehabilitation exercises to sort of relearn some of the coordination after surgery. Tongue, same thing. Tongue stretches, articulation, swallowing, because again, tongue is important depending on which part of the tongue is important for speech and swallow potentially. And so learning to do that and doing some tongue stretches, exercises, mouth opening, stretching. There's a lot of exercises that are done for rehabilitation. And again, if the thing that most people fear is the tracheostomy, or the tube that you get put into the windpipe. It's usually almost always not, I won't say maybe not always. Usually it's temporary, meaning it's usually done to kind of keep everybody safe. There's a lot of reconstruction and swelling, and we're not sure how you're going to swallow safely. We put this breathing tube into your trachea, into your neck, as a temporary sort of to make it easier to breathe, but also if something goes the wrong way, it's easier to suction it out. And that's a I've never had one, but I've seen thousands of them now. So it is a very unique thing to go through, but it is, I try to tell patients this is usually a short-term issue or short-term thing to keep everybody safe. And then that oftentimes can get removed even on the surgery. And once everything's looking okay, the swelling goes down, A percentage of people will actually have the tracheostomy tube removed before they go home or they go to rehabilitation. So those are sort of the challenges with that. And then potentially some, again, like I just touched upon now, is that sometimes you just need a little extra time to kind of get ready to be able to do the things you're used to be able to do for yourself or others. And so not infrequently you would have to go to a rehabilitation place to get stronger, build up your coordination, work on your swallow and everything else, because it takes a lot of care as you can imagine, unless you have somebody 24 hours, 7 days a week, every minute next to you, it's hard to have that care at home unless somebody's with you at all times. Now, there are families who are 100 absolutely able to provide that care. And I always say, if there's a way to get you home, I'd rather you go home than to go to a rehab facility. But oftentimes it's just hard. It's hard for everybody, including the patient. So.
Yeah, I can imagine. I really can imagine. So I see we got about 12 minutes left. So if anybody has any questions, please drop them in our Q&A at the moment. But in the meantime, while we're waiting for questions from the audience, what for people that are potentially hesitant about talking to their doctor or getting vaccinated with the HPV vaccine, what piece of advice would you leave them with at the end of this webinar?
I mean, I think it's partly is you have to, I would think in this webinar, most people are adults, probably not in their 20s, although I may be wrong. You can correct me if you see people who are in their 20s. So it's right now for the audience, it's really I want you to think about it in terms of as a risk benefit sort of strategy game. So what I would say is, and this is how I covered this in our clinic, most of us have a similar sort of chat with patients, is at this stage, you have to sort of look at your overall risk. If you're already monogamous and you're not having any other, you're not exposed to many other different types, the vaccine right now is not going to really help you much at all. That doesn't mean you can't, if, let's say you're 45, that doesn't mean you can't get it. But the chances that likely you've already missed your window where it could have done the most benefit. Although, until you study a little bit more, it's hard to tell, but it's likely. But it's more important, I think, for the audience in this venue is to sort of spread the word to their kids or their loved ones and other younger people that they know or in their families to think about it, because it's really the way I think about it. We've already seen the tide in cervical cancer change dramatically. I think the place where we fall behind right now is young boys getting vaccinated and men getting vaccinated, and because of the stigma or not. And I think the idea is that it's very safe. And like I said, if you talk to any of us, we'll tell you our kids are getting vaccinated 100% of the time for that reason, because if this is a preventable cancer, gosh, I love the sound of that. I mean, I hate the sound of cancer, but to be able to say that we are able to prevent cancers that again are treatable, but the treatment, I will be honest with you, is not fun. Even the HPV human papillomavirus cancers, to undergo either surgery and radiation or radiation and chemotherapy, these are very not fun treatments. They are changing because now immunotherapy is about to get FDA approved for treatment of a lot of these cancers as an upfront treatment. So it is changing sort of the way we're doing it, and we may be able to sort of decrease the toxicity of some of the treatments, but they're still not fun. Imagine getting radiated or surgerized on any part of your tongue or your throat or your nose, or it's not a fun thing to think about, and it's hard to reconstruct, right? But we are very good at it. But it's again, if you can afford and have a way to avoid that, why not do it? It's just and with what we know with minimal to no risk. And so again, those are the most common cancers right now are the virus driven cancers. And like I said, if you can find a way, you can also obviously, the other prevention is change the social norms, change your exposures. That's probably hard to do in these world, in the society we're in. But again, with a simple vaccination, you can really decrease your risk tremendously. For women, it's both for cervical cancer and throat cancer. For
Right.
men, for throat cancer. And so I think it's something to really think about.
And we have a question from the chat that asked, how often should we be getting the vaccine?
So I think a month apart. I looked it up earlier today. But it's usually either two rounds or 3 rounds of vaccination, depending again how old you are when you actually get it. And they're usually a series of shots. So just like for your hepatitis B and other ones where you have to do a series of shots, just like for COVID. Initially, we have to get a couple rounds of shots. It's the same thing. If the younger population really needs two sets of these, but it's either a 2-dose series, a 3-dose series. It's usually 1 to 2 months apart after the first dose that you get it. In the younger population, if it's a two-dose series, it's actually longer. You wait 6 months. So you do one, wait 6 months or at least, and then do another one.
Oh, thank you for answering that question. And we have another question in the chat. It says, are there specific communities that we need to reach out to for education about HPV vaccination?
To be honest with you, I think that there's been a lot of I'm not sure communities, but I think almost always, and I think part of it is just I think that the communities have been disfranchised in sort of in medicine. So the African American people, the indigent poor, the sort of inner city youth, for sure, there's a lot of mistrust, but also just less access to health, right, and preventative
Right.
services. So for sure, always, again, in terms of that population, I think the overall risk for these two cancers developing is, as I told you, is just lower. For whatever reason, there must be some difference between the populations. But still, we have plenty of African American populations, Hispanic populations that have human papillomavirus positive tumors. So it's still definitely a real actor. But really, I think what the main push has been in our main professional societies, AMA and others, American Head and Neck Society, the oncologic societies, is to reach out to primary care. So pediatricians, internal medicine doctors, to sort of make them more fast or make them feel more comfortable to be able to have these conversations with patients, have more information in terms of vaccination, what it offers and how to do it, and actually carry that in their clinics, right? To actually be able to do it in the clinics. There's been a lot of pushback for that, but I think it's slowly making the turn. So I think there's a lot of, and then also not only that, sort of have that be part of the education for nursing students, PA students, nurse practitioners, medical students, right, residents and fellows, to have that be part of not only guidelines but that education. So as they're growing, so that sort of the new wave of medical professionals, it's just ingrained in their minds. Oh, in this age group, you don't have to not only have to get your DTaP, but you've got to get your Gardasil, right? And sort of to make that as easy as possible and get the information out to the patients, and being willing to have those discoveries, because it's not fun to talk about human papillomavirus with young kids, right, or parents, right? But at some point you do have to have that conversation and propose sort of the benefits that this can offer. So it's sort of a multi-pronged approach, I think, with feeling a little bit more comfortable about it, but also have a way to spark that conversation with parents first, and then obviously to get them to have their kids be vaccinated.
I think that is a great point, because I think it's definitely going to take a lot of different points to get everybody where we need to. I agree that vaccination is probably going to be the better route as opposed to getting a broad band of lifestyle change.
Yeah, we're a little. I think the field in general right now is a little in shock and awe, mainly because our current health secretary has an ongoing actually legal filing with Merck and Gardasil against as litigation, which he has not stepped away from, which is amazing that he's a health secretary yet he's not distancing himself from the litigation. Again, from what I know, what we know is there's really no base to the claims that are being formed. But again, I don't want to make this into a political statement or anything else like that. But so there's always going to be the sort of that population or that sort of part where there's going to be people who are anti-vaccines and in terms of fear, but also not understanding what the vaccine actually is, what
But
it
making
does,
an
and
informed
so.
decision.
So yeah, I think presenting it, you can't force people to do something. Well, although we're learning that maybe you can force people to do things, but you're not, that's not how we're supposed to operate as human beings, hopefully. But we at least want to give them the information, and they'll have to make the decision themselves. And you just
Yes.
need to make it approachable, easy to understand, and just have that conversation, right? Sometimes it's just breaking the ice to actually starting the conversation, which is the hardest to do. So.
I agree. I so agree. So before we wrap it up, I thank you. We have 3 minutes left. So before we wrap up, is there anything else you'd like to add or any final thoughts you'd like to share about head and neck cancer awareness or prevention?
Uh, I think, it's when you look at the numbers, I don't think people realize that it's depending on the year, it's either the fourth or the fifth most common cancer. And like I just mentioned, at least in the US, out of all those, many of them are these HPV cancers. So I'll tell you just the typical presentation, just hopefully to maybe I hope that nobody develops this, but the most common one is, I've had a neck lump for a couple months. It hasn't really grown, hasn't given me any symptoms. I finally decided to get it checked out. So what I would say is if you have a lump and you are in your neck, okay, somewhere when you're putting moisturizer, men usually catch it when they're shaving. That's a
Mhm.
common one. I was shaving one day and it just popped out of nowhere. I usually tell them it's usually been there for a while. But women is I was putting lotion on or getting a massage and somebody noted something. So if it's something there and it's something new, you're not sure how long it's been there, just keep an eye on it. If it's still there in about 2 weeks or so, or obviously if it's getting bigger, come in and see somebody. Don't wait. Don't put that off because it may be most of the cases it's nothing, but sometimes it isn't. And so the sooner you get started, the better. Obviously, we know that the ultimate goal is to prevent these cancers, but once you have them, is not to delay care, right, and not to delay access and care and an evaluation of these. So just as you're doing shaving and putting motion on or anything else, just feel for little lumps and bumps as you do that.
One
Okay.
question, what do these lumps and bumps feel like? Like, how do I differentiate that feeling
So I
from
will tell you, you have to be careful because you have some lump and bumps that we all can feel right now. First ones are the submandibular glands right here, right underneath your jaw. You feel like
yeah.
little almonds. Okay, so those
Uh-huh.
are normal. If they're
Okay.
symmetric, usually means that that's something normal. Okay,
Okay.
so
Okay.
that's the one. But that's a sort of a way that you can sort of that it would feel. It'll feel sort of firm, maybe spongy. Oftentimes they're not painful. These are not painful. Sometimes they are, but usually they're not painful. But they'll feel like a mass. They'll feel like a smooth or lobulated mass. It's usually still mobile. Sometimes it's immobile. That's usually when it's a little bit more advanced. But again, I think the idea is just to know your neck, just like people talk about breast exams, testicular exams. As you're doing the shaving, as you're putting the lotion on, just sort of know what's you. And if you start noticing anything different, just pay attention a little bit more to it. Okay, because that's really in terms of prevention or screening, that's the best screening you can get is yourself, is to
Yourself.
actually know is to know how your neck feels by yourself. Yeah.
Yes, to be an expert in our own health. Dr. Leach, I am so grateful for the conversation that you've had with us this evening. It has been a wonderful talk, and I look forward to us hearing more from you and following with your work.
I appreciate it. Thanks for taking the time and spending the time with me. And like I said, I wish everybody a nice, I'm not sure if it's spring or winter or fall right now. Judging from the
Winter.
pollen count, it's probably spring, but it's an interesting part of the year currently. So
Maryland weather, you gotta love it. Have a good night, everybody.
you too. Thanks for having me.
Thank you.
Bye.
Bye.